go.
All right, let's do it. So, good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today's episode is a continuation of last week, part two of what the inpatient palliative care clinician should know about hospice. Our fabulous guest today is Dr. Carrie Liu. She is a board certified hospice and palliative medicine physician, currently serving as the hospice medical director at Providence Hospice of Oregon. A fellow of the American Academy of Hospice and Palliative Medicine, Dr. Liu is passionate about strengthening the culture of interdisciplinary teamwork in hospice and equipping clinicians with the tools necessary to navigate increasingly complex care landscape. She also serves as the board of directors for the Oregon Hospice and Palliative Care Association and has goals of impacting healthcare policy and reform such that we can all practice high quality patient care in a safe and sustainable way. Our format for today is a little bit of a presentation. We'll save a few minutes at the end for some questions. And with that, Carrie, welcome. And I hand the mic over to you.
Thanks, Marty. Appreciate it. And I just wanted to give a shout out to a recent birthday for Katrina. Happy birthday, Katrina. Happy to be here. I will get started. If I can find the right button. Okay. Uh, there's a bunch of different things in here in this talk. Marty and I talked about, I think at some point last year, just how when I switched roles from inpatient palliative to home hospice, there were a lot of things that I didn't know that I didn't know from coming from that prior role. And I've tried to go over several that I found really important these past few years. But also, if there are any other things that you're are burning in your mind just about what's going on in hospice or what would be helpful for you to know, please pop it in the chat and we will hopefully have time for that at the end. Um, just some objectives to go through some of the fraud issues going on in hospice, talking about the difference in terminal diagnosis versus prognosis and how costs have been impacted, talking a little bit about eligibility, and then hopefully some active discussion about ensuring kind of some warmer handoffs, I think, between palliative and hospice. So most people have seen at least one of the headlines surrounding hospice over the past few years. I'm not going to read these out loud, but they're not great. And they're also not false. Fraud is happening everywhere. There's massive amounts of misuse, waste happening, and just frank uh, fraud and harm being done by many hospice organizations. The history of hospice is that in the 1970s, the first hospice was opened. Florence Welsh helped to found the first hospice in the United States. And at that time, there was still highly limited availability and funding for hospice. And then it's really important to note that these hospices that were formed at that time, I mean, some of them are still practicing today, and they've undergone and had to weather a lot of these changes that the newer hospices are just coming into. And then when we move into the next there we go. We move into the 80s, you can see that the number of hospice programs really starts to climb. And then that's when the conditions of participation and the first payment model were formed. And there were at that time just 3 benefit periods, and there were no local coverage determinants for guidelines for eligibility. Into the 1990s, there started to be a little bit better or more well-rounded guidelines, I suppose. The National Hospice Organization gave guidelines for prognosis in some non-cancer diseases at that time. And by 1998, the combined non-cancer percentage had started to grow and was equal to the percentage of CHF, and COPD was the highest. And then into the 2000s, the number of hospice agencies really started to skyrocket. And by 2021, Alzheimer's and related conditions was now equal to cancer as a primary diagnosis. So just as a summary of even just the more recent time period, you can still see that the number of hospices really jumped by a large percentage just in 2 years from 2020 to 2022. And the percentage of for-profit hospices was already pretty high into 2020, but just had continued to rise. It really led to a few different balance issues when you look at the the just hospice in general and what might be the various things that lead to some of the difficulties that people are seeing now. So there is a higher percentage of for-profit hospice than nonprofit hospices. And I do want to be clear that me saying that doesn't imply that all for-profits are bad or worse than nonprofits. There's plenty of good being done on both sides of these arrows here. But I think that it is a piece that's important to call out because it did truly help to drive the discrepancies in what happened in a variety of the places like California and Texas, where the number of hospices really skyrocketed in the highest manner. And then there are shifts in missions and values happening on both sides of these organizations too. Like I mentioned, there's quality work happening on both sides, but there's also high amounts of cost cutting happening on both sides. And some of that's at this time, as we all know, we're in a healthcare system that is I'm going to be diplomatic. It's broken in a lot of ways, and insurance issues is not something that is unique to hospice. So cost cutting and attempting to use resources thoughtfully and fairly is something that we're all facing. Um, it also is a space that opens organizations up to potential inequity or pushing that boundary a little bit too far. Um, the longer length of stay patients is another area which really stood out in the imbalance of how things shifted over the years. As I mentioned, the Alzheimer's and related conditions became the highest primary diagnosis, and those patients often have the longest length of stay. And then they're also more often in assisted living and nursing facilities where there's oftentimes just not the same type of quality of care because of the providers that are in those facilities not always having the same level of training. And then the remaining quality and compliance issues just have to do with, I think, most often the fact that there's so many regulatory asks happening each year, and within the space of the increasing scrutiny, and again, rightfully so, because there's rampant fraud happening. It's really, really hard for hospices to keep up on all of the quality work that needs to be done. Why aren't you going? There we go. So the high cost for care within hospice, it's really caused some issues. Did I miss one? Sorry, hold on. No. Okay. It's really caused some issues because the hospice payment model is a per diem payment model. The routine home care is paid at for days 1 through 60, currently $224 a day. That covers all the costs. I believe Chris mentioned that last week, just to reiterate, and the payment for per diem costs actually goes down after day 60 to 176 days. And then there are different payment amounts for continuous home care or general inpatient level care and respite care, but the bulk of the payment days is at that lower per diem rate. However, long length of stay patients still have the highest amount of spending because of the length of their stay and the just extreme amount of time that some patients are spending on service. It can really create that high cost discrepancy. And then just as an example, additionally, Medicare noted that there's still a high amount of payments for care happening outside of the hospice benefit for hospice patients. And that's another thing that has really sparked in them a need for taking a closer look at what hospice organizations are doing. So they've attempted to look at the payment discrepancies and how do we try to clarify who's responsible for what. And one of the ways that they did this was all the way back in 2013, which was an interesting thing to me to find out since I was doing my fellowship in 2013. They put out a memorandum that really said that Medicare intends for hospices to be responsible for almost everything for their hospice patients. So they should be paying for essentially all the services that are reasonable and necessary for palliation and management of the terminal condition and related conditions. So again, it's all over the place where they say that they feel that virtually all things are related to end of life care, and that the language shifted at that time from hospice being responsible for paying for things related to the primary hospice diagnosis to hospices being responsible for paying for all things related to the terminal prognosis and all of the related conditions. That's a big language shift, and it's not something that I think was fully understood or put into practice as Medicare intended in 2013 by many hospices. And this is even at hospices just that are out there doing really good work. This became very clear even by me attending AHPM, I think 2 years ago, and seeing some of the conversations about this very issue and relatedness, and how in 2023 we're having this conversation 10 years after this memorandum came out. And so you can see how Medicare is kind of unhappy with what the payment landscape was looking like. Just to go into relatedness a little bit more, because I do think that this is something I wish I had understood a bit earlier. I think it is helpful for palliative clinicians to understand this piece because it impacts the handoff of how patients come into hospice and how it feels for them when they get there. So first, we're trying to say, is this related? Is this diagnosis related? Is this medication related? And then when it comes to medication or a treatment or intervention, is it reasonable and necessary as part of the hospice plan of care? I talk all the time about hospice it's not black and white. There is almost no black and white within hospice. Despite having very extensive conditions of participation, it's so much gray, and it is very difficult sometimes to put pieces together for people. The National Alliance for Care at Home, or the NHPCO, as this tool was labeled, has a couple of really good relatedness tools that you can refer to and just read through for trying to learn the process of determining relatedness. So at the top here, again, they talk about just the terminal prognosis, but that for related diagnoses, they also contribute to the terminal prognosis. And then they also care about any symptoms that are exacerbated by any of these diagnoses. So first, you're identifying the terminal hospice diagnosis, or the principal hospice diagnosis, which should be the diagnosis that's primarily impacting their prognosis. And then you're going to look to, are there any other diagnoses, conditions, or symptoms that are caused by or exacerbated by the principal hospice diagnosis? If yes, and it's related. If no, are there any additional diagnoses, conditions, or symptoms that contribute to the 6-month or less prognosis? If yes, then it's related. If no, are there additional diagnoses, conditions, or symptoms that are caused or exacerbated by treatment of the related conditions? If yes, then it's related. So it's a good example, again, of why CMS expects that almost everything should be related. In that case, that explains why CMS feels like here, hospice is responsible to cover medications needed to manage or palliate the conditions that are related. So any drugs that are unrelated to the terminal illness or related conditions should be rare. Um, and that's a thing that really, when I started here a few years ago, it there's been a lot of evolution in people's understanding of relatedness. And like I said, it's not unique to any one hospice. I think it was really something that hospices everywhere were still kind of struggling to put into place. Um, I think a couple of good examples that I've seen and heard directly from folks that are still practicing palliative struggle with as I've accepted referrals would be dialysis, I think is a good one here. I think when I was practicing inpatient palliative, there were far more times where we would see a patient go on to hospice and still be able to easily continue their dialysis because the hospice was able to say that they felt like it was not related, and the carve out phrase I think would happen quite often. And I think the hospices were trying to make that best determination. I do think that patients should be able to continue their dialysis even when they go on to hospice. But you can see how, given that many times the renal failure is very clearly related based on that workflow we just went through there, it is um, it's really not a financially feasible thing for hospices to pay for dialysis for patients. When a dialysis session can cost, over over the amount of a per diem payment, and they get dialysis 3 times a week, it's not something the hospices can easily take on. And that's a difficult, just kind of moral and ethical thing to try to navigate for hospices. Um, so CMS has put a lot of work into attempting to decrease the amount of fraud happening. Um, it's it's again a necessary intervention. Truly, we have to figure it out. And not just because of the waste of money, but because truly the poor care that happens in these situations is just not acceptable. And it's something that we all need to be concerned about, whether or not you're actively practicing in hospice or palliative. Um, there's an enhanced state survey process. There's more unannounced surveys, which are a great and important thing, a tool for Medicare to use. There's also increased audits. Again, I think audits are a necessary piece for high quality care, but they're they're really difficult for hospices to endure sometimes. Even for hospices that are out there doing the good work and just trying to stay afloat amidst the uh, you know base per diem and the ever increasing costs of healthcare, to then have to navigate and audit that. For example, if you get one of the audits that looks at some of longer length of stay cases, you could get asked to pull a number of cases and have to provide records for a patient that was on service for a year or over a year. And then the the organizations that look at that audit case may come back to you and say, no, we don't think that this patient was eligible for hospice. And then if you want to appeal that, you've got to go through things even more. When I can tell you that if a hospice is a good organization and is really doing their best to try to make those eligibility determinations in an ongoing manner, to have to go back and work hard to defend the decisions that were being made in a case potentially 5 years ago, just so that your hospice doesn't lose, um, you know, hundreds of thousands of dollars in claims that would be taken back from you. It's a really tough thing for hospices to survive, especially a lot of the smaller hospices that are out there. This is a huge undertaking to have to go through these audit processes. And I think they're really important. It's just that I think there's still work to be done in making sure that they're as impactful as they can be, and less of a drain on the hospices that we don't want to lose out there. For palliative clinic providers, I wanted to make sure to include something for you, because I do sometimes still see this question as well about, can I still see my patients when they enroll in hospice? Um, there we go. Uh, so the first question is, are you the hospice attending? In which case, yes, you can still see your patients when they're in hospice. Are you a physician or a nurse practitioner? Because that does impact if you could see a patient if you are covering for your clinic colleague. Because if you're a physician, you can cover for your physician colleague and still potentially bill for that visit. But if you're a nurse practitioner, you can only bill for the visit if you're the person that's specifically listed as a hospice attending for the patient. Um, is the visit reasonable and necessary for the hospice plan of care? This is something that I think Medicare really is probably going to be putting a lot more attention on still over the next years, because I still see a lot of visits happening where they're just kind of routinely being seen, the patients, for maybe a yearly follow-up or something like that is what was documented as a reason. And that is not something that Medicare ideally wants to see happening in the way that I interpret the regulations, I should say, because they really want those extra visits that are happening or any costs that are being submitted outside of the hospice benefit to be a necessary additional thing. So instead of just a routine visit, for example, like the hospice attending would want to be seeing a patient and billing for a visit for an unmet symptom need, in which case that would be an appropriate thing to submit a bill for. And then when you're determining the type of bill to submit, it's really related to relatedness. So is it a visit for something that's related to the terminal prognosis, which we discussed is almost everything, in which case you would use that GW or GV modifier, sorry. And then if it's unrelated, there's the GW modifier to use. Um, it's this slide is just an example that the efforts since 2010 to improve non-hospice payments for hospice patients is mixed in success. So part A for hospice patients, there shouldn't really be charges going into part A because part A is what should be happening primarily just under hospice that has replaced the regular part A. So those kinds of things are still happening when patients may go to the emergency room. A hospice patient goes to the emergency room and gets admitted to the hospital, but nobody realizes that patient's on hospice and um, charges get put in still under Part A when really anything that happens in that forum should be paid for by the hospice organization. Ideally, a visit to the emergency room was approved by the hospice and any care that happened there. Again, all of that cost should come from the hospice's per diem um, payment pool already. So that spending did decrease, but Part B spending increased from 2010 to 2019. So physician services for things that are outside of the hospice benefit went up in that time period, which, as I just talked about, again, with the relatedness piece, most things should be related. So, physician services uh, going up by this amount, again, I think it's just an example of how we just don't have it quite right yet with the education out there on what type of spending and the correct way for billing to happen for hospice patients. And then just a few added complexities would be talking about hospital issues with the pressure to discharge. It's super real, and I think the biggest fear from hospice organizations is how that impacts the choices that may be made by hospitals as far as the quality of the hospice that they're referring to and the quality of care that's happening then when those patients are leaving the hospitals. But there's still no space. I mean, I get it. I felt that pressure all the time when I was working in the hospital, and that was a few years ago. I'm sure it hasn't gotten any easier since then. Healthcare workers are exhausted. I mean, I'm not, clearly. I don't look it at all, right? But everybody's tired. Everybody's tired. And it's so hard to dive into uh, you know, document more, spend more time on the pieces of the work to defend your medical decision making, so that when you get slapped with all of these increased audits, you can defend the care that you did and the work that was done. It's so hard to spend so much time doing that when you're so tired and you just want to take care of your patients. Um, Nursing home staff, again, I mentioned earlier, it's just happening, I think, more where they're they're also just trying to get by and they're having to hire staff that just don't have the same level of training. It opens things up for errors, medication errors are in the home or in the nursing homes are still such a high issue, and the regulations in facilities are also increasing in large part because of that. And then general inpatient level hospice care. I didn't spend a whole lot of time. I didn't spend any time on this today yet, but it's a huge area of scrutiny because it's the highest reimbursement rate for hospices and ties tightly to whether or not Medicare patients meet those eligibility criteria for that level of hospice care in an ongoing way. And that's a thing that I think is oftentimes difficult for folks in the hospital to recognize that sometimes what you may feel is a patient that should qualify for that level of care. Hospices now are forced to be really highly scrutinizing of patients that they're admitting onto that level of care. Um, the referrals for both palliative care and hospice, I think, is an important piece where we can continue to have impact on just the quality of care that's happening. Earlier referrals for palliative care is an area where just it's not where it needs to be, and then I think that then further impacts how and when patients come onto hospice. The median, I know I mentioned the long length of stay hospice patients, but the median hospice length of stay is still wildly low. And patients are getting to us, sometimes with just days, and that's not the benefit that they should be receiving. It's a benefit that they've paid for and that they deserve to have access to if they want it. And we're just not doing a good enough job for people yet. Eligibility is a complicated uh, topic. I'm going to talk a little bit about it in the next slide too, so I'll save that one. Education in residency and in fellowship is we don't spend that much time on the business aspect of medicine in general, and I did not get much education on the hospice conditions of participation in my time. I think that's changed a lot and is continuing to change. And I think that fellowship is such a short time for hospice and palliative medicine physicians that it's really important in those early career years to figure out ways to build in some additional education to sort of shore up your understanding. If you do go into a palliative position, recognize the importance of also still putting some additional focus on your hospice education in that initial time period. I think would be really helpful. And then the education for patients and families up front, it's super helpful to have a better partnership in that area. And pay attention to the quality of the organizations that you're referring to. As far as eligibility, this is an important topic because the local coverage determinants are Medicare is very clear. They're meant to be a guide, not a substitute for the physician's prognostic determination. This is something that, again, I spoke to the audits happening earlier. It's really impacting the way that um, hospices are having to view eligibility at times, and oftentimes driving things, I think, a little bit too far for fear of those audits because when cases are having to be defended in the third level of appeal, for example, before the administrative law judge, um, you're seeing that in the first couple of levels where the audit reviewers were looking through the cases, they're really diving directly into pointing out like this patient is not eligible or was not eligible. You didn't show it because they didn't meet every checkbox in the LCD for renal failure or for dementia. And and you're then having to have these conversations with the administrative law judges trying to say like, but they don't have to meet every checkbox because we believed they were eligible because of this, and this other issue that was clearly showing that they were still declining and demonstrating that progression of their disease. And it's a difficult thing. It is something again where I think more partnerships for documenting upfront from the palliative physicians and nurse practitioners in the hospital or in the clinics why they're also believing and supporting eligibility is just further assistance for your hospice colleagues. Um, Oops, there we go. And then the last just summary was just again in-depth assessment, trying to help identify any patient needs in the hospital, making sure that if there is a borderline eligibility case, it's great to have a conversation with your hospice colleagues. It's great to have that documentation in your notes continue partnering with educating other hospice or hospital providers as far as their determining of eligibility as well. And in clinics, recognizing that there are going to be patients that have to be discharged, and how do we work to partner with ensuring those back and forth handoffs appropriately. Um, Pre-admit case reviews are helpful in the sense that not just for eligibility determination, but for complex symptoms that come up. I appreciate so much being able to talk with my hospital colleagues to get a handle before the patient leaves the hospital on making sure that we have all the right pieces in place for getting them nice and comfy from moment one when we take over their care. And then if there's patients in the hospital that don't have an adequate symptom management plan and go out the door to a home environment or a facility environment, it's not a straightforward process. That's a huge burden on the hospice that's taking that on to try to have enough staff and support to be out there for the length of time needed in those initial days to get things under better control. So making sure that ideally that's more controlled if possible, but then if not, that there's partnership and a plan for how that is to unfold. And then sending patients with meds in hands, knowing your hospice formularies, knowing what facilities are looking for their med orders is really helpful. And then I think that a tool that we use here is doing live admission calls for hospice with our hospice admission nurses and the physicians doing the certificate of terminal illness, which really is helpful in just getting a good starting point for symptom management too. Thanks.
Thanks, Carrie. That was outstanding. I will admit there were some things in there I didn't know that I didn't know, especially how almost everything seems to be related and not making promises here in the hospital. In the comments, we don't have any questions. We have lots of expressions of appreciation. So I will send you with one quick question, and then we'll let you go for
Okay.
the day. And it's that um, we I am wondering what medications I might be using on my end that I think are really great that maybe make your life harder. And I'm thinking about things in particular like transdermal buprenorphine is now the latest and greatest, and I'm trying to send patients out with these things, but I don't know if this is something that hospice is struggling with, what the costs are. Are there certain meds that we are using that are making your life more challenging that should be on our radar?
Um, transder That's a great question. I appreciate it. Transdermal buprenorphine is a medication that is very costly still. I am a huge fan of buprenorphine, and I have high hopes that all forms of it will be more cost appropriate and accessible soon. But yeah, that's a thing that I navigate, and I think here we navigate with just trying to go through what we have to go through for every question when we're addressing any medication coming onto hospice is there an appropriate formulary alternative? And um that sometimes the answer might be yes to transdermal buprenorphine and sometimes it might be no, right? So I that's a medication that I provide my own self in my own practice here. But it's not something that I'm able to just maybe go to as freely and often as I would like. Do you have
Yeah.
any other examples burning in your mind?
Well, I know of some other longer acting pain meds that are extraordinarily expensive, but I'm so used to navigating those already with insurance. There are certain like long acting hydromorphone, extraordinarily expensive option that even patients in clinic I have a hard time with. So I don't think I would even send somebody out to hospice with something like that because it just wouldn't make sense. It would break the bank. And there's not really an advantage to it. I mean, buprenorphine's unique in that it has some unique advantages, and that might twist my arm a little bit. But maybe if they're at 20, maybe I can go up to something like a sublingual or some other form that's more cost effective as well.
Um, yeah, I think that that's exactly it. That's the that's the thought process. I think in general, um, in just the inpatient world, you oftentimes have just like this bubble
Mm,
about having to think about insurance and cost issues. You're mentioning in the clinic space, being thoughtful about that very issue. And I think that's the biggest help. OxyContin.
mm,
I don't think that there are probably many hospices that are going to be able to pay for OxyContin, for example, because for that one, there is often an appropriate, cheaper option. And so let's not use OxyContin as much in patients where we know that we're about to, probably head towards hospice. Another, I guess, straightforward example would be something like empagliflozin or the SGLT2s that are for a heart failure patient in the hospital. Um, it's a great tool for many patients, but I've had a not small number of patients who were started on that med like a week before then they were referred to hospice, and it's it just doesn't quite mess up or match up the messaging for if you're going to be starting that med and want to see that that med is impactful in decreasing your mortality. Maybe hospice isn't the quite the goal. But if not, then again, maybe let's not just like start that med right in that moment and send them out the door for hospice to then have to say that is not yet something that we can easily cover for a formulary medication. So
yeah.
hope that makes sense.
Thank you. We appreciate all the work you do out there.
Oh, thanks. Well, I appreciate you and all the work that you all are doing still. It's great if there were not that many questions. Maybe I just answered all the things that people had that they were curious about.
I think so. All right, guys. Have a wonderful weekend.
Thank you so much, Marty. Thanks for having me.
You're welcome. Toodles.